Sir, thank you for those kind words. Thank you, organizing committee, for giving me this opportunity. So, in next 15 minutes or 20 minutes, I am going to talk about this new molecule, that is Dospata, that has come up for our rescue in relapse and refractory FLT3 positive AML. So, AML, we all know how we treat AML. We go to the induction, then there are some responders. For responder, we do the consolidation either with the chemo or for the transplant. And there are some relapses, again we go for the salvage, and there are certain patients who are refractory to the first induction, they become non-responder, and again we search for the salvage. This salvage could be chemotherapy, it could be targeted therapy depending on the mutational status, then we transplant, and then there could be the clinical trials, which of course which are much lesser in our country, but still they are there. So our goal for relapse and refractory AML is to ultimately achieve the second CR or sufficient reduction in the disease burden so that patient undergo transplant. So many salvage therapy regimens have been proposed, but still there is no standard of care. Every institute has their own protocols. With that, they are comfortable, they use that part. Choice of therapy has multiple aspects: patient characteristics, age, comorbidities, PS, and the pre-existing myelodysplasia, which makes the most important criteria. Again, the duration of the remission is also important. Late relapses, which suggest some chemotherapy responsiveness, or early relapse, which is less than 12 months, and they are chemo-resistant part. Usually, once the patient has received the first line therapy and achieved CR, we do follow up of the patients up to 5 years with the CBCs. The patient who relapses, we again do the comprehensive genomic profiling and then identify which is the good option for that patient. This was around 2024 NCCN guideline for such patients, and their targeted therapies have come into the action now more and more with the newer molecules. So we have gilteritinib, we have HMAs with sorafenib, quizartinib, and gilteritinib single agent also. And there are other mutations like IDH2, we have enasidenib, we have IDH1 mutation, ivosidenib, and we have CD33 positives, and gemtuzumab ozogamicin. If available, we can use that part. Otherwise, we can go to the aggressive part of the therapy. Now, AML is a heterogeneous hematological malignancy. We all know these are the frequency of selected genetic mutation which can seen in the AML. Now, if you see, 37% of the mutations are FLT3. So almost 1/3 of the patients have FLT3 mutation, followed by the NPM1 and then DNMT3 mutation. 2% of the patient in the last part is the TP53, which are very difficult to treat. We are today focusing more on the FLT3, both ITD as well as TKD. So this is the FLT3 receptor, which is most commonly mutated in the AML. There is an immunoglobulin-like loop in the center, then there is a receptor transmembrane domain, then there is an ITD tandem duplication, and then there is a tyrosine kinase domain. The mutation can happen at the TKD, or there may be tandem duplication at this ITD part. FLT3 is basically constitutive activation of transmembrane receptor. Its mutation leads to proliferation, but it blocks the differentiation. Right? 30% has ITD and 7% has the TKD mutation in overall 37% of the patients. FLT3 AMLs are associated with poor outcomes, as we all know. So, the patient presents with the high WBC count, they have the high levels of peripheral as well as the bone marrow blast, high LDH levels. Mutation is associated with the increased risk of relapse, shorter DFS and shorter OS. Even in the relapse, if they are FLT3 positive, their outcome is very dismal compared to those patients who are not FLT3 positive. So, either in the first line or in the relapse setting, if you have FLT3 mutation, your outcome is going to lesser than compared to other counterpart who does not have that mutation. So, current treatment approach for FLT3 AML, newly diagnosed FLT3 AML patient, induction, you give midostaurin to 7+3, patient achieves the CR, go with the consolidation high dose cytarabine with midostaurin, or autologous or allogenic transplant. Patient who are refractory to induction or who relapse after the transplant, you need salvage therapy, again high intensity or low intensity therapy. Multiple case series have shown that FLT3 status can change during the course, as patient might have the FLT3 mutation in the first part, they are likely to carry in the second part, but those who do not have the mutation in the first part can still develop the FLT3 mutation in the relapse setting. So, it may evolve during the progression. So, Dospata gilteritinib is a new oral potent, highly selective FLT3 inhibitor. We do have previous FLT3 inhibitors like sorafenib, which is non-specific, then we have midostaurin, which is more of a specific pattern, and now we have gilteritinib, which has a single agent activity in relapse refractory FLT3 mutated. It is active against both ITD as well as TKD, and also has a weak activity against c-KIT mutation. It also inhibits the AXL mutation, which we already have known that it is also a poor outcome factor. and it is involved in the FLT3 resistant mutation. So in phase 1-2 study, single agent therapy with the 80 milligram dose resulted in sustained inhibition of the FLT3 mutation, and combined CR rate was 41% in patients with relapse refractory FLT3. So ultimately, phase 3 they have suggested 120 milligram dose. The first study came was the Admiral trial. So Admiral trial design, they have included the adult AML patients who are refractory or relapsed after the first line AML therapy. Whether they have done transplant or not, that is okay with that inclusion criteria. FLT3 mutation has to be there, FLT3 ITD or TKD 8335/I836. Either in blood or bone marrow, whatever the sample you have taken, that's fine. Stratification was response to the first line AML therapy, whether relapse is within 6 months or after 6 months, and then pre-selected chemotherapy, whether he has received high intensity or low intensity chemotherapy, and co-primary endpoint was OS and CRs. Around 371 patients were randomized, 2:1 randomization, gilteritinib single agent 120 milligram, around 247 patients, and salvage chemo was 124, followed by the transplant. For gilteritinib arm, again the patient was kept on the maintenance gilteritinib for that patient. High intensity regime for the MEC or FLAG-IDA, while low intensity is low-dose cytarabine or azacitidine. As you can see the result, around 34% of the patient in the gilteritinib arm response versus 15.3% in the salvage therapy arm. Even if you see the CR rate, that is the second bar, 21.1% as complete CR, while that is in only 10.5% with the salvage chemotherapy regimen. So the risk difference was around 8.6 percentage points, and for CR it is around 10.6 percentage points, but almost double the risk. If you see the OS at 1 year, gilteritinib has shown the significant better overall survival compared to the salvage chemotherapy arm, and the median OS was with the gilteritinib arm, it is around 9 months versus salvage chemotherapy around 5.6, so it is almost clinically double the overall survival rate, and 12-month OS was 37% versus 17%. More patients proceeded to transplant also, obviously achieve more patients who are in the CR, they can go for the transplant. So around 25.5% versus 15% of the patients who ended up in the transplant in both the arms. Transfusion independence was achieved in 35% and maintained by around 60% of the patients with gilteritinib arm compared to the salvage chemotherapy. And there is also OS advantage when censoring for the transplant. If you have done the transplant, your outcome is going to be better, but if it's censored, if you have done the transplant, what is the outcome? Again, gilteritinib shows superiority with 8.3 months of median OS versus 5.3 months of the OS when salvage chemotherapy is considered. So, whether you do a transplant or not, compared to the salvage chemo, gilteritinib is shown to be beneficial. Prolonged survival, again patients who resumed the gilteritinib, their overall survival of 16.2 months versus those who did not resume the gilteritinib 8.5 months. So it looks nicely, but there may be multiple factors like patients have post-transplant complications and all that which may have affected this outcome. But in general, if the patient receives the gilteritinib and maintains the maintenance of gilteritinib, outcome is going to be better. So treatment emergent adverse event. Now this is an important slide. Most common fatal events were infection. 3 patients had pneumonia, intestinal perforation and septic shock. Another is the QTC interval prolongation, which is related to gilteritinib in 5% of the patients. Adverse events were 19.34 versus 42.44 versus the chemotherapy arm. As we all know, chemotherapy will have some more side effects, but the important side effects which I would like to say is liver dysfunction, AST and ALT increases is more with the gilteritinib. Hypokalemia and fatigue is also commonly seen. Thrombocytopenia and decreased platelet count was more prevalent with the gilteritinib compared to salvage chemotherapy. Mortality part, if you see at 1 month, only 2% in the gilteritinib group compared to 10% in salvage chemo, and at 2 months it is 7.7% in the gilteritinib arm versus 19% in the salvage chemotherapy arm, which might be affected secondary to the progression of the disease also. Median duration of exposure to treatment, obviously gilteritinib has a better absorption because the salvage therapy has most of the chemotherapy. So 18 weeks patient would able to take the gilteritinib compared to only 4 weeks with the salvage chemotherapy arm. Long-term follow-up, we also have the data 2 years after the primary analysis. So post hoc analysis done. We can skip. So 26 versus 15%. 26.5% of the gilteritinib patients who underwent the transplant during the study received the maintenance, and alive patient without the relapse. These are the numbers. Numbers are very small to say, but still 26 patients remained alive for more than 2 years, 18 who underwent the transplant, and 16 out of which here was started the maintenance therapy. Long-term follow-up again, median survival follow-up has reached to 37.1 months, 1 year OS is 36.6% with gilteritinib and 3 years is 15.8% versus 10% in the salvage chemotherapy. Duration of response was also maintained longer. The CR was 23 months, CR combined was 4.6 months and CR with incomplete hematological recovery was still 10 months. We can skip the adverse event interest during the first year of Tosasa, and after 2 months if you see there are difference in the side effects events also. In the first month most of the events occurring in the first year or maximum in the 2 years, and after 2 years, after earlier, the side effect profile becomes less common and patients are able to tolerate more, except for the liver problem which still persists even after the 12 months. The second trial which I want to discuss is Komodoro trial. This was an international multicentric open label phase 3 trial, particularly in the Asian patients. Yes. So there is again gilteritinib versus salvage chemotherapy. They were equally balanced between them. Median age was around 50. ECOG performance status, most of the patient has 0 or 1. FLT3 alone in 91% versus ITD was on 91%. TKD was on 6 to 11%. Group was also divided fairly with the intermediate in 80%, unfavorable 2% and favorable in 10% of the patients. Here also if you can see the survival, 1 year survival was 35% with the gilteritinib versus 25% for the salvage chemotherapy arm, and the OS was better. Again median OS you can see here also in Asian population also 9.6%, which is similar to the Admiral trial, and salvage chemo is also the similar like 5 months. So across the globe the outcomes have remained the same. CR was also better. CR with combined CR, that is hematological and incomplete platelet recovery, they are also better with the gilteritinib arm. Grade 3 or more events are lesser with the gilteritinib compared to the salvage chemotherapy arm. So safety and tolerability was good. Median duration of exposure was 113 days versus 28 days. If you adjust for that, still the grade 3 event was lesser with the gilteritinib. The most common adverse events were anemia, thrombocytopenia and pyrexia and increased LDH. For salvage chemotherapy again it is the hematological malignancy which is most common. AEs leading to death occur in 20% of the patients receiving the gilteritinib versus 15% of the patient chemotherapy respectively. So the summary, gilteritinib significantly prolongs the OS compared with salvage chemotherapy in patients with FLT3 mutated relapsed refractory AML in Asia. When adjusted for the treatment exposure, safety and tolerability was favorable with this drug compared to chemotherapy, and the result of this study further validated and affirmed the clinical efficacy and study data of Admiral study. Timing of response, this is another study, how early it can give the response. So among both the trial, they have pulled the data who has received the glomerular. So 205 patients who achieved the CRs from the 2 phase 2 trial. So what they see was 30% achieved the early response, that is by the end of cycle 2, and 70% has achieved after cycle 2. And amongst early response, out of this 60 patients, 13 has achieved the complete CR, remaining were the CR with incomplete hematological or platelet recovery, while those who achieved the late CR, around 50% of them achieved the complete CR. So this is something unusual. While we consider that early response is associated with more CR, here late response is associated with more CR and less of the incomplete recovery. Similarly, if you see the first graph, there is a rising number of patients who achieve the CR. So at the end of 2 cycles, 36.1% achieved CR combined, which increases to 71% when you complete 4 cycles, which again increases to around 90% when you complete the 6 cycles. So what this data suggests, that you should give this drug for around 6 cycles to achieve whether the drug is completely responding or patient is not responding to this drug. Efficacy is the patient achieved CR with full count recovery prior to on study HSCT were more in the late response than early response. As I have mentioned, CR rates were more common with the late responses patients. Grade 3 or higher treatment events adjusted by the total duration, again 22.2 versus 30.5. So late responses, less side effects later on. Drug related grade 3 or higher events were 10.6 in early response versus 6.5 in the late response. And treatment discontinuation due to disease relapse was 41.7% in early versus 27.6% in the late response, and progression was also higher those who respond early compared to those who respond slowly. So this is something unusual, and we have to keep in mind that we have to keep this drug going on, and those who respond in the later part, they tend to have the response longer period of time. So most patients with relapsed refractory FLT3 mutated AML achieved CRs within 6 cycles of gilteritinib monotherapy. You need to continue it. Those who tolerate the drug should be considered given the possibility of achieving late sustained remission, and there is still a need to differentiate the timing of response assessment and treatment continuation decisions for gilteritinib from that of the salvage chemotherapy. With that, I end of my talk. Anyone has any experience or things to say, we can do that.
Thanks, Sanket. That was really awesome.